All right, Assalamu alaikum. Welcome back, everyone. I hope you enjoyed your break. My name is Saba. I will be the moderator for this next session, supporting the mental health needs of elderly Muslims with Dr. Akber Mithani. I am the volunteer lead for our organizing committee this year, so I'm really excited to be here with all of you. Um, just a couple of housekeeping items. Again, our speakers are happy to answer questions during the Q&A period, so feel free to post them in the Q&A chat box. As always, feedback for the session and conference will be provided digitally after the conference with a Google Form survey. So today's session, so Sunday, December 12th, is accredited, including the research poster session. So in order to obtain accreditation hours, please complete the Google Form survey, which will be sent to you after the conference. And just to point you towards some resources, you can find those resources at muslimmentalhealth.ca. And lastly, feel free to post about the conference on your personal Facebook, Instagram, Twitter using the hashtag CMMHC 2021. So I am going to go ahead and introduce our speaker for this session. So Dr. Akber Mithani is currently the Regional Medical Director for Fraser Health Long-Term Care and Assisted Living Services and a Clinical Associate Prof at the Faculty of Medicine at UBC. Dr. Mithani has worked in a variety of clinical admin positions, such as Director of the Geriatric Program and Vice President for Medical Affairs at Providence Healthcare. And Dr. Mithani has also been Director, Primary Care of the Elderly Research Group, Providence Healthcare, Vancouver, BC, and has participated in over 30 peer-reviewed funded research projects, abstracts, books, and journal publications. And currently, he supervises and teaches residents. His area of expertise includes clinical issues around frail elders, especially in long-term care. And so with that, I'm going to hand it off to Dr. Mithani to take us through this awesome session.
Thank you very much, Sabah. Welcome all of you. An honor for me to be able to present some of the interests that I have in this area. I hope that your conference is going very well, inshallah. So we'll start. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Assalamu alaikum jami'an wa rahmatullahi wa barakatuh. The topic, of course, that I have is around specifically talking on depression and anxiety in the elderly and looking at a biopsychosocial spiritual approach. Disclosures that I have are listed here. They really relate to a lot of the grants that I hold in some of my research work that I do in geriatric psychiatry and long-term care in particular. So those are my disclosures. I'm going to go straight into the whole topic. The first thing and the most important to understand when it comes to major depression and anxiety disorders, and especially when I talk about depression, and especially as it relates to the Muslim population. And in a lot of the times when we talk about the Muslim population, we're talking about very much different cultures within the Muslim population. And so some of the most common things that we see is around the whole area of anxiety as part of the depression spectrum, right? And what we see is that a lot of our patients, especially Muslim patients, present with underlying anxiety as a predominant symptom of their depression. And that is something that we have to be very cognizant of. In the geriatric population, especially in the frail elderly population, the anxiety that they have actually manifests most of the time with somatic symptoms. And so you will have a lot of your Muslim patients present to you with somatic symptoms, and you'll see that they've been extensively investigated, right? So they have had numerous consultations with specialists and so on and so forth to rule out organic causes and so on and so forth, and you just can't find anything. And it really is underlying presentation of anxiety in the manifestation of somatic symptoms that is the predominant feature of people presenting with underlying depression. So irritability, worrying, guilt, and we'll talk a little bit about guilt. It's very important for this population, especially restlessness, nervousness, tension, problems with concentration, of course, anhedonia, insomnia, fatigue. These are a lot of the neurovegetative symptoms of depression that this population presents with. Now, if you look at some of these studies, and this study comes from the United States, and if you look at sort of community-based presentations of depression, you will see that, and I think this generally applies, to our population, the Muslim population, quite significantly. If you take 200 depressed people in the community, only 40 of them actually present to the family physician, only 20 of them have any psychological symptoms that are detected, only 10 of them are correctly diagnosed, and actually only one of them is adequately treated. And that is really, when you look at this, it's quite concerning, because if you look at the whole area of depression, as you all know, 80% of depressions are actually treatable, right? And so it's a little bit concerning when you have 80% of your depressions are actually treatable, and we're not actually recognizing and adequately treating the patients. There's not a lot of illnesses in medicine where you can actually say that 80% is treatable. So, especially in primary care, the presentation of depression, you will see, I've listed 4 of the common symptoms that I really see amongst the Muslim population, especially, and one is around pain. And pain is extremely common. Underlying presentation, we'll talk a little bit about pain and pain syndromes later on, fatigue, sleep difficulties, and as I said, anxiety, usually manifesting as somatic problems. So these are some of the common things that we see in the presentation of depression in the geriatric population. Now, how do we diagnose depression in the frail elderly population? And especially, I want to highlight some of the common ways that we see the manifestation of depression, especially amongst the Muslim population. And I have a mnemonic here, and it's called depression, and it deliberately has 2 P's and 2 S's in it. It's not a misspelling. The first thing, of course, you'll see is diurnal variation, right? They get worse in the morning and they get better as the day goes on. And you will see that even in a lot of their symptoms, they're worse in the morning, it gets better as the day goes on. They can have a lot of decrease in their energy, fatigue, tiredness. Those are some of the common ones that you see. They can, of course, present with psychomotor agitation, or they can present also with psychomotor retardation. And I found psychomotor agitation in the frail elderly to be a more common manifestation as far as symptomatology is concerned than psychomotor retardation. They can, of course, present with underlying psychosis, and a psychotic depression is, an urgent situation, especially in the frail elderly, and can be treated very well with certain modalities, which we'll talk about in a minute. But psychosis, and the 2 common psychosis that I see with the frail elderly is either a paranoid delusion or a somatic delusion. And so what they present with is they stop eating and drinking because they think, their food is being poisoned, or they stop taking their medications because they think you're poisoning them, in which case it may not be a delusion because you are poisoning them. But actually, They have this, they stop their regular medications because they think somebody is poisoning them. So that's a common delusion that they present with. The other common delusion, of course, is a somatic delusion, pain being one of the common somatic delusions, and they complain of pain that physiologically doesn't make any sense, organically doesn't make any sense. Or they get, and you will have seen this, I think, in many of your patients, they get preoccupied with their bowels, right? One of my teachers said to me that if an elderly person can talk to you about their bowels for 15 minutes without being interrupted, they have depression until proven otherwise, right? So very common for them to present with somatic and paranoid delusions. The R, of course, stands for restlessness, irritability, and anxiety. As I said, 60 to 90% of our patients with underlying depression present with anxiety symptoms as part of their depression. Decrease in eating or decreased appetite is something that you will see they present commonly with. And of course, they have sleep issues. Now, remember, as people get older, there is fragmentation of their sleep, but in the classical cases, they present with early morning awakening, right? So, you know, they're wide awake at 4 o'clock in the morning, and they basically don't know what to do. And in the Muslim patients, you really have to get into the sleep properly, right? So if they go to sleep at 10 o'clock and they're waking up at 5 o'clock in the morning, that's not early morning awakening, right? That's a darn good sleep, right? You know, that's not early morning awakening. Of course, our Muslim patients do have the habit, and they get into the habit of waking up early in the morning to say their Fajr Salat, right? So the fact that they have conditioned themselves that they're waking up early in the morning to recite their Salat, that's not early morning awakening, and that has to be distinguished with a change in their sleep pattern as one of the symptoms that could be pointing towards an underlying depression. I complained of somatic complaints, and suicide is very important. Now, you know, suicide is something that's a very touchy subject, especially amongst the Muslim population, because you will see that a lot of the Muslim populations, you know, the Islamic teaching is around how life is, you know, a gift from Allah subhanahu wa ta'ala, and the fact that if you take your life, you've actually committed a big sin. However, we must distinguish that from the fact that suicide may actually be a very important symptom of an organic illness like depression, of a neurotransmitter deficiency in the brain, you know, resulting from that. And so sometimes then when we talk about how socially we are able to manage our Muslim patients with depression, this is an area that's very important. And I've seen, unfortunately, even you know, some of our Islamic scholars in our communities, when somebody has a depression and has attempted suicide, there is a blame or a shame that's put on that person, that, you know, you're inadequate, you know, you've tried to take your life, and how could you possibly do that when you know that, you know, life is a gift from Allah, and so on and so forth. It's very important to be able to understand that that person's, you know, act of trying to attempt or commit suicide is, you know, a part of a symptom, and it's not something that needs, you know, that should be blamed on them for being inadequate from a spiritual perspective. A lot of the Muslim patients especially have passive suicide. So what they do is they actually you know, will, you know, they won't go out and jump off a bridge or hang themselves or anything like that. What they do is they stop taking their medications, they stop eating and drinking because they feel that life is not worth living. So you have to be able to tease that out, especially in your Muslim patients. Loss of interest or anhedonia, a common symptom of depression, especially in the elderly population and in the Muslim elderly population. And sometimes in this population, as you know, physicians and healthcare professionals, we don't ask about, you know, sexual health and so on and so forth, especially in the geriatric population. But we need to understand that, you know, the elderly population also have you know, a need for you know, intimacy with their you know, spouses and so on. So the loss of interest really needs to be teased out with this particular population. Ongoing weight loss, of course, clinically significant weight loss once you have ruled out all the other causes. You know, organic causes will you have to have depression as part of your differential diagnosis. And the other one is that they present with a decreased cognition. So these are some of the things that you need to be aware of as far as the diagnosis of depression is concerned in the geriatric population, especially if they have, especially if they are Muslims. You'll see in this particular list that I don't have mood in this list. And the reason I don't have mood in this list is, by and large, the overwhelming majority of the patients, especially the Muslim patients, if you ask them, are you depressed? They will say no. They are not depressed. And so they shy away from the psychological symptoms a lot more. And we are therefore focusing a lot more on the biological symptoms or neurovegetative symptoms of depression. Now, once you have a patient that you have diagnosed with depression, then of course, the first thing you want to do is to rule out any organic factors that may present as depression in the geriatric population. So metabolic problems such as hyponatremia. Hyponatremia is very common in the way it presents with in the geriatric population. They feel tired, they feel fatigued, they have muscle aches all over their body. They don't want to do anything, they just want to stay in bed all day. It looks like depression. So you want to make sure that you do a workup on that person before you confirm your diagnosis of depression. Endocrine, of course, the classic you'll see is hypothyroidism, and clinically significant hypothyroidism in the geriatric population can manifest itself with classical depressive symptoms. And so you want to make sure you do TSH on these patients. Of course, medications, there are many depressogenic medications. Common one that I find sometimes we ignore are non-steroidal anti-inflammatory drugs. Remember, the non-steroidal medications normally, they do not cross the blood-brain barrier. But as you get older, your blood-brain barrier becomes leakier and leakier. By the time you're about 75 years old, you haven't got a blood-brain barrier. So when you take a non-steroidal anti-inflammatory, it crosses into the central nervous system quite commonly. It can cause confusion, it can cause a lot of other things, but it can present as depression as well in the geriatric population. So important to understand that. Infection, of course, especially some of the common brain infections like neurosyphilis, HIV, TB, can present as depression. Cardiovascular disease, especially congestive heart failure, because decreased perfusion of the brain as a result of congestive heart failure can present with some of those neurovegetative and biological signs of depression that we talked about. Inflammatory disease such as lupus can present with neuropsychiatric symptoms. There's a study that shows up to 20%, even as high as that in the frail elderly population, can present with the neuropsychiatric symptoms that mimic depression. Of course, the most important other one is neoplastic or neurologic, and that's, gives you weight loss and fatigue and tiredness and all of those other symptoms. and you want to make sure that there has been a good workup on underlying potential neoplastic or neurologic symptoms like a CVA or a stroke in this population. And inshallah, this is not a problem with the Muslim population, although you'll be surprised that we still have Muslims who like to drink and have alcohol use disorders and so on and so forth, but that can also present with symptoms of depression. So this mnemonic is medicine, just gives you a little bit of an idea on how you can make sure that you're looking at organic factors as well that may present as depression in this population. So I now want to just talk a little bit about treatment, and of course the treatment, is multi-pronged in this population, in the frail elderly population. Psychological treatment is important, and the gold standard is cognitive behavior therapy. Remember one thing, that cognitive behavior therapy, to do cognitive behavior therapy, the patient needs to be cognitively intact. Yeah, I've seen some people who do cognitive behavior therapy in people who are cognitively impaired, and let me tell you, it's not going to work. So cognitive behavior therapy in people who are cognitively intact, I think one of the things that we don't actually explore this very well. We have in Vancouver an Islamic scholar that has gone through extensive training in psychosocial rehabilitation, cognitive behavior therapy. And when it comes to, and we work closely together in our community with this Islamic scholar who's an imam of a community, where we're having him do cognitive behavior therapy, which is aligned with the belief system and the faith of the Muslim patient. And it's actually very effective in mild to moderate depressions. Medications, of course, are important. And I'm not going to go into the details of medications because all of you are probably very much aware of the medications that we use. The standard, even treatment, the gold standard in treatment of depression with pharmacotherapy in the frail elderly is with the SSRIs. And probably the two SSRIs that I use the most are escitalopram and sertraline. Are the two ones that I use the most. The one caution I have is in the use of fluoxetine. So fluoxetine is a very activating SSRI, causes a lot of agitation, especially in the geriatric population. And I would say to you that you should not be using fluoxetine in the frail elderly population. The reason is that fluoxetine has a metabolite by the name of norfluoxetine, which has an extremely long half-life. So if you have a frail elderly person who is on fluoxetine and they get agitated on fluoxetine, they will remain agitated for 3 months even after you stop the medication. So it's one of those SSRIs that we tend not to use. We use, of course, polytransmitter agents such as SNRIs like venlafaxine. Remember, venlafaxine at low doses, even in the frail elderly population, is just an SSRI. It's not until you get over the doses of 150 milligrams that it actually starts to act as a polytransmitter agent. There is, of course, mirtazapine, which is a medication that we use commonly in the frail elderly population, especially if they have problems with sleep at night, because it has some sedating properties, and so on and so forth. Bupropion can also be used, a little bit more activating, and my experience with bupropion is it's not, in terms of efficacy, it's not one of the best drugs that we use in the frail elderly population. And then there are some other specialized medications like duloxetine, for example. Duloxetine is a medication that's supposed to be, it's not just supposed to be, but it's quite good in people who have depression with underlying pain syndromes as part of the depression, especially if they have neuropathic pain. It's a drug that works very well. One of the problems in British Columbia with fluoxetine is, of course, it's not covered, and so it can be quite expensive. But so you have a whole array of medications that you're able to use for management, for pharmacological management of depression in the geriatric population. But it's important then to understand, and I know this is basic, but sometimes we forget these medication management strategies, especially when it comes to the frail elderly population. And the first thing is optimization, right? So what happens is in a lot of people, they get started on an antidepressant, they get on a certain dose, but then the medication is not optimized, right? It's not taken to its highest dose. And so the first thing is to optimize the medication, make sure that you're using appropriate doses, understanding that in this frail elderly population, it will take 4 to 8 weeks for the medication to actually start showing its real effects. Substitution is obviously possible, and you technically can substitute from one SSRI to another because SSRIs are different as far as their structure is concerned. I tend not to do that. I tend mostly to substitute from one class to another class. So if they have not shown any effect on one SSRI, I'd probably go to a polytransmitter agent much more commonly. The one thing that we use quite often in management of depression is a combination therapy. So if I have somebody who's on an SSRI who has had a partial response to an SSRI, I will combine and add another medication like mirtazapine, for example, as a combination agent. And then, of course, there is augmentation. And the most commonly used augmentating medication is lithium. We can also use cytomel, which is T3. We can use T3 as well, but lithium is the most common augmentation agent that we use. But what I want to say is that ECT, electroconvulsion therapy, is the most safest and the most effective treatment for depression, especially for psychotic depression. The problem with ECT, of course, is the whole issue of resources in the community, access, and so on and so forth. But there is a huge cultural and what I call a spiritual bias when it comes to the use of electroconvulsive therapy for the treatment of depression, right? And for our Muslim patients, especially, it's a tough conversation to try and convince them that ECT can actually be a life-saving intervention for the treatment of depression, especially if they have like a psychotic depression or they stop eating and drinking because they have paranoid delusions and so on and so forth. Or in fact, if they may have suicidal thoughts and suicidal ideation. It is something that takes a lot more time to try and convince our Muslim patients about the importance of this as a genuine intervention for the treatment and management of depression. I'm just trying to look at my time so I'm not going over, and somebody will tell me if I'm going over time. The most important thing that the rule of geriatrics, of course, is that you start low, you go slow, but you aim high. And that's where that optimization issue comes when it comes to the frail elderly population. So please starting them at very low doses and then titrating them upwards as we go on. I want to talk now a little bit about the spiritual approaches and when it comes to the management of depressions. And this is a very important area, especially when we are managing our Muslim patients. There are many, many believers, Muslims, who tend to equate depression with spiritual inadequacy. And this is further exacerbated by some of our Islamic scholars, members of the community, even wise members of the community, who basically just want to say to people, you shouldn't be depressed. You know, if you just have tawakkul on Allah subhanahu wa ta'ala, you seek refuge in Allah, you know, you're just not connected with God, because if you were connected with God, then you would not be feeling, you know, and you would not have symptoms of depression, you would not have any psychological problems, and so on and so forth. And then the question comes, you know, because this is a mental illness, of course, you know, is it really Islamic to treat with, you know, medications, right? And you know, because it shows that you're inadequate spiritually, and now you're treating that person with medications. And they'll say, should we just not focus on dua? Should we just not focus on salat? Should we just not focus on the rituals of Islam and the rituals of religion? Because that, if we were to do that, that is going to you know, help in the management of depression. And a lot of the times I sit with my Muslim patients, and I actually spend a lot of time in this area with them, because I talk to them about, you know, how depression, the biological depression that we're talking about is basically an imbalance of chemicals in the brain. And I say to them that it's no different than diabetes. A lot of my patients actually are also diabetic. And I say to them, it's no different than diabetes, which is, you know, an imbalance of insulin in your body. And I equate it, I medicalize it for them, so that I want to make them understand that, you know, just like diabetes is a resultant of a deficiency of insulin, in this way, the illness that you're suffering from, depression, is a result of a deficiency of certain chemicals in the brain that's causing you to have this. And trying to make sure that they understand that this is no different than treating diabetes, you know, with anti-diabetic medication. And so, you know, that's what we need to focus on. The other thing is to really work with them and having them understand the essence of what I call practical tawheed, right? In this comprehensive, multi-pronged treatment approach. What do I mean by that? So what, you know, as the Holy Prophet, sallallahu alaihi wasallam, as he said, that, you know, what you need to do is, yeah, you need to have tawakkul on Allah. You need to have refuge in Allah subhanahu wa ta'ala, but you need to tie your camel as well, right? So you need to do your part, and then you have refuge in Allah subhanahu wa ta'ala. And what I say to them is that, you know, the effect of the medication is actually from Allah subhanahu wa ta'ala. And that is important for this folks to understand, that we as physicians, as healthcare professionals who are prescribing this medication, we are just a zariya, right? We are just an agent, right? You know, you know, that is manifesting, you know, the beautiful name of Al-Shafi, of Allah subhanahu wa ta'ala. You know, it's a manifestation of that name. So we are just, you know, if you want to call it, you know, a wasila, you know, that that Allah is using us as a means towards the effect that He has put in the actual medication. So what I say to them is that the effect, the antidepressant effect of the medication comes from Allah subhanahu wa ta'ala. He has put that effect in that medication. So ultimately, the healer is Allah. That is what is important for them to understand, that the ultimate healer is Allah. This is practical tawheed, right? That the ultimate healer is Allah subhanahu wa ta'ala. And the effect of that medication, the antidepressant effect, is from Allah. And so what we need to do is we need to take that medication, because that's the means through which Allah will heal you of this particular illness. And so you have to do your part, and then you leave it to Allah to put that effect in the medication, so that you can be treated for this horrible illness. The social supports and environment become very important. And this is where I think the role of the community becomes very important. So rather than developing a community based on shame and blame, I think the education of the community becomes very important to understand that this is a real illness, and building a mental health support system around the whole community with a wide variety of expertise, right? Whether they are physicians, nurses, pharmacists, ethicists, Islamic scholars, counselors, different types, so that people who are suffering from this horrible illness actually have a means to get information. Families have a means to get information. The community is adequately educated about this, so that there is a support system that builds up and supports this person as they are going through the very difficult times of this illness, where they need adequate support, to manage this. Social support and the environment therefore become a very important part of the management of depression in Muslim communities. And in some of our communities here in Vancouver, we have that support system, and it works beautifully. It really does. And we have a team of people that support. We have a telephone that they can call. We do regular education on mental illness and mental health with our community, so that they're educated. And you should see the relief that the members of the community have when you actually talk to them, because they don't feel that they're inadequate anymore. I want to just talk a little bit about this whole area of spiritual pain, right? We have, physiological pain, we have psychological pain, but we have spiritual pain. And the spiritual pain is something that our depressed Muslim patients suffer from a lot, right? And the biggest manifestation of underlying spiritual pain is that they have guilt, and they end up having guilt of their past sins that they have committed. And the person in spiritual pain tends to dwell on this past, their past sins that they've committed, and then their transgressions that they've had, and they cannot get over that, right? And I think it's important to, talk to them about the fact that, one of the biggest sins that a Muslim can actually commit, to be honest with you, is losing hope in Allah subhanahu wa ta'ala, right? And as you know, Allah is the most beneficent and the most merciful. We say Bismillah ar-Rahman ar-Rahim, right? His rahmah, his mercy is huge. And of course, one of the manifestations of the mercy of Allah is that He actually makes you forget your sins, because He wants you to move on in your life, right? So you will see a lot of us who have committed sins in our past. You will see that we tend to kind of forget our past sins as you lead your life. When you have a person in depression and suffering from spiritual pain, those thoughts, those sins and transgressions come back, as part of their depressive syndrome, right? But we need to understand and talk to them to make them understand that, there is a hadith, that, the mercy of Allah that is in 100 parts, and only one part of that 100 parts of His mercy has been manifested in this world, right? And so we say to them that once you've really repented, once you've done tawbah, once you've done istighfar, right, then be confident that His mercy has encompassed you and that He has forgiven you, and you have to move on in your life, right? And that's part of the cognitive therapy, but it's also very important, I think, for the Muslim patients to actually have that conversation with them when they're suffering from spiritual pain, especially. I want to just say a couple of things about COVID and the mental health manifestations of COVID in our population, Muslim population especially. I've got only a couple of minutes left, I see. Um, the most important thing about COVID is it has had a tremendous effect on the frail elderly population, right? One is from social isolation from the community and the spiritual centers. And what happens, and I've seen this, people who are predisposed to depression, and I haven't talked about the predisposition to depression and the genetic connections and all of that stuff, that's for another time. But people who are predisposed to depression, what COVID has done with the social isolation from the community and where spiritual centers were closed, right? Mosques were closed because of public health orders and so on and so forth. It has actually exposed and manifested that underlying preponderancy of depression. It has manifested it in this population. So, the social isolation from the community has had a tremendous effect, especially with the closure of the spiritual centers. And my plea to communities is that when and wherever the public health orders in your province, where they allow you to even have a small gathering with social distancing and everything, if you are allowed to do that, then be brave and put in those, SOPs to make sure that you open up the center a little bit, for people to be able to reconnect to their community as well. The other, of course, manifestation in this population, it is that it has resulted in a delay in medical care, especially in some of the screening that elderly folks go through, especially screening around cancers and so on and so forth. It has delayed in the medical care of this population, and a lot of them have actually ended up passing away because they have not received timely care, right? There has been an absence of spiritual care and support as a result of COVID because the centers have been closed. Some people have tried to, create online support systems and so on and so forth. But remember, online support for the frail elderly is challenging for them, right? So, the virtual solutions are sometimes not adequate, right? There are many frail elderly population that we have in our community. They don't even know how to use a computer or a phone or something. They rely on their children and their grandchildren to connect them. And if their children and their grandchildren do not live with them, they can't connect, right? And then what has happened is there's been an eruption of multiple Zoom sessions where the frail elderly population, they don't know what to connect to. First of all, they don't know how to, they don't know what to connect to, and they get pretty fatigued out with the virtual technology as well. There is, of course, been a tremendous effect in visitation restrictions, especially in the sector that I work in a lot, which is long-term care and assisted living. Where there has been restrictions in visitations, and a lot of my Muslim patients who live in long-term care and assisted living have not had the benefit of family connections because there's been restrictions in visitation. I had one of my patients, when I was explaining to my patient, well, we have this visitation restrictions from the public health experts, and these are laws we cannot break. It's to protect you and to protect others. And interestingly, this patient said to me, you know what? I'm in long-term care. I don't have a long time to live. I'm quite happy to pass away with COVID as long as I get people and my family to come and visit. And it's heartbreaking sometimes when you hear stories like that. So COVID has had some really significant impact on the mental health of the frail elderly population. And I think as communities, whatever we can do to help this population and reconnect them with their families and their communities, I think will go a very, very long way in managing them. So in conclusion, I just want to say depression is common, treatment is multifactorial, medical and spiritual approaches go hand in hand, should be used together. Remember the essence of practical tawheed. Medical treatment effects are from Allah subhanahu wa ta'ala. The mindset is very important. Of course, the rituals of Islam, du'as and worship and salat have a significant role, especially in prevention. I haven't talked a lot about that, but they have a significant role in prevention. Remember, depression is one of the most treatable illnesses. And I want to leave you with this thought that in medicine, there are many illnesses that take away your life, but depression and anxiety is one of those illnesses that takes over your life, and that is not appropriate. We have the tools to be able to treat our patients with depression, our elderly patients with depression, and we should use everything we have to make sure that we improve the quality of their life. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much, Dr. Mithani, for that extremely informative session. You know, personally, although I'm not a clinician by trade, I think the clinical approaches that you mentioned, as well as the spiritual approaches, as well as the intersection of both of them were really interesting and very informative. So thank you so much for that. So we're going to move on to our Q&A session here, and we have quite a few questions coming in. So I'm going to go ahead and start off with the first one here. So is there any research showing non-pharmacological therapies being effective in the elderly with depression? So example, exercise or social activities, etc.
Excellent question. I'm so glad somebody asked this question. So the one thing that has absolutely shown to be very effective is exercise. And I would say to you that if there is nothing else that you do with your frail elderly population, the one thing you can do is to tell them to move, right? Make sure that they're moving. And it doesn't matter what they use, is a walker, cane, whatever is safe for them, but they have to move. So exercise has been shown to be one of those things that that is the most important treatment for depression. It's obviously not a treatment, and it's, you see, when you're talking of an organic illness, right? An illness that is related to some imbalance of chemicals in the brain, exercise on its own is not going to be your only treatment modality. So I'm coming back to you with the same message, right? That treatment is multifactorial. And so exercise is definitely one of those things that has shown to have an effect on a positive effect on the mental health. The other things, it says other social activities and stuff. One of the other things that has had, there hasn't been a lot of this in the frail elderly population, a lot of research in this in the frail elderly population, but there is some research in the community-based population, and that is brain stimulation, right? So brain stimulation in the sense of, you know, giving them exercises to do, brain exercises to do, right? Sudoku and all of these other things that kind of, you know, now with technology the way it is, there's tons of things that, you know, you can give them, and many apps that can stimulate the brain of the person, and that has shown to have a positive effect on mood and anxiety. As far as, you know, proper studies, you know, double-blind, you know, type of studies, there is not a lot of that. There is a lot of naturalistic studies that show this kind of effect from those modalities.
Awesome. Thanks for answering that question. So we're going to move on to the next question here. So can you touch on how we can assist the elderly who might become dependent on rapid acting anti-anxiety medications, but fail to see the value in long-term medication use?
Yeah. So I don't know how to answer that question. Rapid acting anti-anxiety medications, I think you're talking mostly of benzodiazepines. I gotta tell you, benzodiazepines should be used with extreme caution in the frail elderly population because of their sedating effects, because of their ataxic effects, and so on and so forth. And so I think that I would not say that never use them, because I use them as well. But I think what is important is to actually sit with the patient and tell them that, talk about the pros and cons of the various medications and the potential side effects like falls and so on that can have a huge impact on the life of that patient. But sometimes what we do is we use the short-acting kind of benzodiazepine for a short time. And I don't think there is a problem in that, as long as you're using it for a short time, when you're using the other medications like the SSRIs, for example, to have their effect. The effect of the SSRIs, like I said, can take between 6 to 8 weeks in this population. And in the meantime, you may have to give them something. And then you need to make sure that you taper that dose off. So it's a tough one, because a lot of our patients want that immediate effect of their anxiety symptoms, and they don't want to invest in the long-term gain for the kind of initial pain that they may have. So it's all, I think, about sitting down with the patient and educating them and how we can make sure that we are managing their acute symptoms, but at the same time we have a long-term plan where the other medications will be tapered off. One of the problems we have is we start benzodiazepines, we also start the SSRIs, but when then the patient gets better, we don't have the courage to taper off the benzodiazepines that we actually started, which was really a short-term intervention. So I think it's making sure that you educate the patient and you have a clear plan in place, and you have the courage that you will taper off the short-term medications once they've been tapered. Once they've been once the effect of the SSRI has kicked in.
Awesome. Yeah, that makes sense. Thanks so much for answering. Yeah, we have a ton of questions coming in. I'm going to go to this one here. Can you speak to the importance of human touch with the elderly?
Yeah. Extremely important, human touch. The evidence of human touch, and there are other aromatherapies and things like that, are not well established in the treatment of depression, in the treatment of major depression in the geriatric population. But I can tell you that, as one of the multifactorial treatment modalities, just having human touch, and you'll see in our facilities and our long-term care facilities where we have some fantastic nursing staff who actually spend time with the residents that we have in long-term care. And when they are just sitting with them and they're just holding their hand and they're, calming them down, it has a tremendous effect on their anxiety levels, especially in those people who have cognitive impairment also as part of their syndrome of illnesses, the mental illnesses that they have. Now, I know that some of the neurologists or neuropsychiatrists in this group may tell me some wonderful neural pathways that can explain this effect. I'm not as familiar with them. I'm not a neuropsychologist or a neuropsychiatrist or a neurologist, but I certainly think that this is a very important modality. One thing that I have found, especially in touch also, is when it comes from your own family member. I think that becomes even heightened as far as the calming and anti-anxiety effects that it has.
Awesome. Thank you so much for answering that question. I think we'll ask one or two more questions here. The next one is, how can we facilitate connecting elderly with mental health supports if there is a fear of medications, fear of mental illness, or fear of being diagnosed with dementia?
I think that most important is to focus on education, right? So it's all about educating the communities, right? There is, look, I mean, we have to accept what we have to accept, right? We have in our communities, in the Muslim community, there is a taboo around mental illness. It is what it is. And I think that, there is an uncertainty, there is a fear. I think there is a huge cultural bias with respect to mental illness. So it's not just, Muslim communities. I think I see sometimes the same challenges that our Christian, friends go through, who are from the same culture. So we have Arab Christians, we have, South Asian Christians and others who go through the same challenge. I think a lot of it is cultural as well. And I think what we have done sometimes, and I come back to this whole area of spiritual inadequacy, and I find this to be the most concerning, where the rhetoric amongst members of the community, as well as some scholars, Islamic scholars, so-called scholars, is to really downplay the whole area of mental illness and make them feel that their problem is spiritual. Their problem is not mental illness. Their problem is they have not connected to God, and they have not connected to Allah. And I think that's a dangerous, slippery slope, to go through, right? So it's really working with the Islamic scholars of your community. It's working with the leadership of your community to educate, to make people feel comfortable and say, you know what, this is one of the chronic diseases that unfortunately we may suffer from, and we have to have a way where we can deal with it, and do not try and Islamicize something that really isn't there. So that's my advice.
Yeah, absolutely. Thanks again for answering that. I'm gonna ask one more question here. I guess the last question for us today. So this one's asking, so ECT causes significant memory loss and requires sedation. Is TMS a better potential solution?
Yeah, transmagnetic stimulation has not shown huge efficacy in the frail elderly population. I have to tell you. Number one, it doesn't, it's a resource that's not available in many communities, in many cities even. There are very strict criteria as to who can get TMS and who cannot get TMS. it's almost impossible for me to have any of my patients qualify with respect to criteria for TMS in British Columbia. I don't know about Ontario or other places. It doesn't seem to be the effectiveness is not huge with treatment of severe depression in the frail elderly population. Now, a lot of studies have not been done in this population, unfortunately, around TMS. Theoretically, you would think that it would be just as good, at least it would be good, but we haven't had a lot of studies in it. Access in some of the cities is just very limited, and the criteria for eligibility is almost impossible for me, for my frail elderly population, to refer them to a TMS program in British Columbia. So it's not something that I have a great experience in because of that. As far as memory loss is concerned, yes, there is memory loss with ECT, but remember that a lot of the memory loss that you see with ECT is actually around the illness that they have themselves, right? And they're so distraught with the symptoms that they have around the illness that they actually don't mind not remembering that, in the future. So it's all about balancing the risks and benefits. I still think that ECT is the safest and the most effective treatment for depression, and probably underutilized, especially in our population because of some of the taboos that come with ECT.
Awesome. Thanks again so much, Dr. Mithani, for, this extremely beneficial, session, as well as answering our questions today. And I know a lot of people have benefited from this session today. So thank you again.